Hi everyone, my name is Ashley Barklin. The case study that I chose to discuss is hypertension. The case study reads as follows. The Dallas County Medical Examiner's Office calls to inform you that you are investigating the sudden death of one of your patients. The patient in question was a 55-year-old black woman who had been followed for many years in the hypertension clinic. Workup at various times had revealed no evidence of renal disease or endocrine abnormalities. On a recent office visit, her blood pressure was measured as 190/105. A few months ago, she was briefly admitted to a hospital after she awakened at night feeling short of breath. Review of hospital records for that admission showed that she had mild ankle edema, basilar rales, hepatomegaly on initial evaluation. A chest X-ray showed cardiomegaly and slight atrial enlargement. On an ECG confirmed left ventricular hypertrophy. Laboratory studies at this time suggested slight hepatic damage. Serial cardiac serum markers, enzymes, and troponin were negative for myocardial infarction. Over the last few years, there have been a steady increase in her serum BUN and creatinine. The medical examiner relates that the patient complained of sudden, sharp, severe chest pain and collapse at her husband's softball game. She was taken to a hospital where she was noted to be hypotensive with unequal pulses. A chest X-ray revealed a left pleural effusion and a widened mediastinum. An autopsy is being done to determine whether she died from some catastrophic vascular event related to hypertension. Hypertension is a major problem and contributes to many life-threatening diagnoses. The first article, titled Hypertension, that I chose discusses the different aspects of this issue. This is the leading risk factor of heart failure, coronary artery disease, congestive heart failure, stroke, myocardial infarction, and end-stage renal failure. This article states that pathophysiology of primary arterial hypertension is unknown, although it has a genetic disposition, but secondary is not unknown. It is usually an early onset, there's no family history, and there is a clear cause. In an effort to reduce hypertension, at-home monitoring is encouraged to patients. Studies have shown people to be more compliant when they can take charge of their own health care. The goal is to educate patients to be more compliant when they can take charge. The goal is to educate the patients that hypertension can cause a multitude of problems and they must play a part in making lifestyle changes. As for the treatment, there is both pharmacological and non-pharmacological. In some cases, only one or the other is needed, and in some other cases, both are necessary to control hypertension. Given the series of events in the case study and the symptoms, there are key indicators that appear to be giving a glimpse into the patient's future. One possibility could be aortic dissection. The second article that I will discuss is Presentation, Diagnosis, and Outcomes of Acute Aortic Dissection, 17-year-old trends from the International Registry of Aortic Dissection. Data was collected from 4,428 patients between December of 1995 and February of 2013. This study was initiated due to the fact that acute aortic dissection is difficult to diagnose and treat as it presents many challenges. The dissection occurs when there is a tear in the aortic intima, allowing for a hematoma to form. From this, the blood propagates along the aorta, compromising the vessels and the valve function. This then causes a domino effect in which the blood ruptures into the pericardial space, pleural space, or mediastinum. This is the reason that acute aortic dissection is a medical emergency. Chest pain is the classic presentation. Many are diagnosed during autopsy, although there is a significant amount missed because autopsies are not done that frequently. This study showed that the most notable changes over time in diagnosis and treatment of aortic dissection include the frequency in which a chest X-ray was ordered as primary imaging. There was also an increase in normal chest X-rays. Surgical interventions increased over the 17 years, which showed an improvement in mortality over time as well. The topic that I would like to discuss next in this case study mentions that the patient had left ventricular hypertrophy confirmed on the ECG several months prior to her death during her hospital admission. The article that I chose is titled Electrocardiographic Predictors of Sudden Cardiac Death in Patients with Left Ventricular Hypertrophy. This article notes that sudden cardiac death is a major health problem in the United States. It claims between 250 and 300,000 deaths annually. The survival rate after sudden cardiac death is less than 5%. Left ventricular hypertrophy is associated with sudden cardiac death with evidence of electrical abnormalities. This can be diagnosed with both an ECG and an EKG. Studies have shown that prolonged QRS duration on an ECG in these patients is a risk of sudden death. After completing multiple studies, it was shown that an echocardiography has a higher sensitivity for a diagnosis of left ventricular hypertrophy than an EKG. Many more aspects can be measured and assessed with this type of technology.